Welcome to Week 3. Last week we learned how to measure disease frequency, incidence, prevalence, mortality. This week, we're taking the next step, measuring associations between exposures and outcomes. This is where epidemiology gets powerful. It's not enough to know that 10% of people have diabetes. We want to know, are smokers more likely to have heart disease? Do people who exercise have lower cancer rates? Does this intervention reduce mortality? Measures of association quantify these relationships. By the end of today, you'll understand relative risk, odds ratios, attributable risk, and number needed to treat, and when to use each one. Before we calculate any measures, let me introduce the 2x2 table, the fundamental organizing structure for epidemiological analysis. Draw a table with 2 rows and 2 columns. Rows represent exposure status, exposed on top, unexposed on bottom. Columns represent disease status, disease on left, no disease on right. This gives us 4 cells. Cell A, exposed people with disease. Cell B, exposed people without disease. Cell C, unexposed people with disease. Cell D, unexposed people without disease. From this simple table, we can calculate almost every measure of association. The row totals, A plus B and C plus D, tell us how many exposed and unexposed people we have. The column totals, A plus C and B plus D, tell us how many diseased and non-diseased. Let me give you an example. Studying smoking and lung cancer, A equals smokers with lung cancer, B equals smokers without lung cancer, C equals non-smokers with lung cancer, D equals non-smokers without lung cancer. I want you to practice constructing 2x2 tables. When you read a study, mentally organize the data this way. It makes the calculations intuitive. Relative risk, also called risk ratio, is the most intuitive measure of association. The calculation is simple, risk in the exposed group divided by risk in the unexposed group. Using our 2x2 table notation, that's A plus B, divided by C plus D. Interpreting relative risk is straightforward. An RR of 1.0 means equal risk in both groups, no association. An RR greater than 1 means the exposed group has higher risk. An RR less than 1 means the exposed group has lower risk, the exposure is protective. Let's work through an example. In a cohort study of smoking and lung cancer, 100 smokers, 10 develop lung cancer, risk equals 10%. 100 non-smokers, 1 develops lung cancer, risk equals 1%. Relative risk equals 10%/1% equals 10.0. We interpret this as, smokers have 10 times the risk of lung cancer compared to non-smokers. Or, smoking increases lung cancer risk 10-fold. Relative risk can only be calculated from cohort studies or randomized trials where we follow people over time and calculate actual risks. It cannot be calculated from case control studies, where we don't know the true risks in the population. The odds ratio is another measure of association, primarily used in case control studies. In a case control study, we start with cases and controls, then look back at exposure. We can't calculate true risks because we selected based on disease status. Instead, we calculate odds. The odds ratio is the odds of exposure among cases divided by the odds of exposure among controls. In our 2x2 table, that's AC divided by B/D, which simplifies to add/BC, the cross-product ratio. Here's the key insight. When the disease is rare, typically less than 10% prevalence, the odds ratio approximates the relative risk. This is called the rare disease assumption. So even though we can't calculate RR directly from case control data, the OR gives us a good estimate. Odds ratios are also produced by logistic regression, which is why you see them throughout the medical literature. Multivariable logistic regression produces adjusted odds ratios controlling for confounders. Interpretation is similar to RR, or equals 1 means no association, or a 1 means increased odds with exposure, or 1 means decreased odds. But remember, odds and risk aren't the same thing, so be careful with language. While relative risk tells us how many times more likely disease is, risk difference tells us the absolute excess risk. Risk difference, also called attributable risk, is simply the risk in the exposed minus the risk in the unexposed. Using our smoking example, 10% minus 1% equals 9%. This means 9% of smokers develop lung cancer that wouldn't have occurred if they hadn't smoked. Or, among smokers who develop lung cancer, 9 out of 10 cases are attributable to smoking. Why does this matter? Consider two exposures both with RR equals 2. Exposure A, risk goes from 0.001% to 0.002%. Exposure B, risk goes from 10% to 20%. The relative risk is identical, but the public health impact is vastly different. Risk difference captures this, 0.001% versus 10%. For healthcare managers, risk difference connects to real-world impact. If an intervention reduces surgical site infection from 5% to 3%, the risk difference is 2%. For every 100 surgeries, you prevent 2 infections. That's actionable information. Relative measures tell you about strength of association. Absolute measures tell you about public health significance. You need both. Number needed to treat, or NN, takes risk difference and translates it into clinical practice. NNT is simply 1 divided by the absolute risk reduction. If a statin reduces heart attack risk from 8% to 6%, the ARR is 2%, and NNT is 1 divided by 0.02 is equal to 50. You need to treat 50 patients with the statin to prevent 1 heart attack. Lower NNT means more effective intervention. An NNT of 5 is impressive, treat 5 people, help 1. An NNT of 500 means treating a lot of people for modest benefit. But context matters enormously. An NNT of 500 for preventing hangnails is not worthwhile. An NNT of 500 for preventing death might be very worthwhile, depending on the treatment burden and cost. NN also depends on baseline risk. The same relative risk reduction produces different NNTs in high-risk versus low-risk populations. Treating high-risk patients produces lower NNTs, more bang for your buck. For healthcare managers, NN helps with resource allocation. If 2 programs both reduce heart attacks, but one has NNT of 30 and the other NNT of 100, the first is more efficient. Combine NNT with cost data and you're doing cost-effectiveness analysis. Number needed to harm is the flip side of NNT, it quantifies adverse effects. NNH is 1 divided by the absolute risk increase of the adverse effect. If a medication causes nausea in 10% of treated patients versus 2% on placebo, the ARI is 8%, and NNH is 1 divided by 0.08 is equal to 12.5. For every 13 patients treated, 1 additional patient experiences nausea. Higher NNH is better, you can treat more patients before causing 1 harm. An NNH of 1000 means harm is rare. An NNH of 10 means significant harm. The power comes from comparing NNT and NNH. If a drug has NNT of 20 for preventing heart attacks and NNH of 100 for causing serious bleeding, you prevent 5 heart attacks for every serious bleed. That might be worthwhile. But if the same drug has NNH of 15 for causing kidney damage, now you're causing nearly as much harm as benefit. Different calculation. For healthcare managers, this framework supports formulary decisions, guideline development, and patient communication. What are we likely to achieve? What are we likely to cause? The numbers help balance benefits and harms systematically. Population attributable risk extends our thinking from individuals to populations. Individual attributable risk tells us the excess risk for an exposed individual. Population attributable risk tells us the excess disease burden in the whole population due to the exposure. The calculation accounts for how common the exposure is. An exposure with RR of 10 but 1% prevalence contributes less to population burden than an exposure with RR of 2 but 50% prevalence. Population attributable fraction, PAF, expresses this as a percentage. What proportion of cases in the population are attributable to the exposure? If smoking causes 85% of lung cancer cases in the population, the PAF is 85%. This guides public health priorities. Eliminating a common exposure with moderate risk might prevent more disease than eliminating a rare exposure with high risk. Healthcare managers making prevention investments should consider PAF, not just relative risk. For example, alcohol causes fewer individual-level problems than heroin, but alcohol's population attributable burden is enormous because so many people drink. From a population health perspective, addressing alcohol might have greater impact. Let me apply these concepts to cardiovascular disease using Canadian data. Smoking roughly doubles to triples cardiovascular risk, let's say RR of 2.5. Hypertension has RR around 2.0. Diabetes also around 2.5. Each is a significant risk factor. When people have multiple risk factors, the risks often multiply. Someone with all three might have RR approaching 2.5 times 2.0 times 2.5 is equal to 12.5 compared to someone with none. This is why risk calculators include multiple factors. But remember, relative risk doesn't tell the whole story. A 30-year-old woman with RR of 12 for heart attack is still at low absolute risk because her baseline risk is tiny. A 70-year-old man with RR of 2 might have higher absolute risk because his baseline is substantial. The Framingham Risk Score and its Canadian adaptations estimate 10-year cardiovascular risk using age, sex, blood pressure, cholesterol, smoking, and diabetes. This absolute risk guides treatment decisions. We treat high absolute risk more aggressively. For healthcare managers, understanding both relative and absolute risk helps you design appropriate screening and intervention programs. Who benefits most from aggressive treatment? Those with high absolute risk, regardless of relative risk. Let's summarize our measures of association. Relative risk tells you how much more likely disease is in the exposed compared to unexposed. It measures the strength of association. Calculated from cohort studies and trials. Odds ratio is the case control equivalent. It approximates relative risk when disease is rare. You'll see it constantly in the literature because logistic regression produces ORs. Risk difference tells you the absolute excess risk, the public health impact of the exposure. A high RR with tiny risk difference might not be important. A moderate RR with substantial risk difference is a priority. NNT and NNH translate these measures into clinical practice. How many do we treat to help one? How many do we treat before harming one? This supports benefit-risk decisions. Population attributable risk considers both strength of association and prevalence of exposure. It guides population-level priorities. For healthcare managers, these tools help you evaluate evidence, allocate resources, and communicate with clinicians and the public. Is this intervention worthwhile? How big is the impact? These measures provide answers. Next week, we begin study designs, starting with descriptive epidemiology. How do we generate the data that goes into these calculations? Assignment: find a study in a medical journal that reports relative risk or odds ratio. Calculate the risk difference if data allows. What's the NNT? Come prepared to present. See you next week.